Hello viewers, welcome back to another episode of Swastivani, where we bring you inspiring stories from the changemakers of public health. I am Veena Shree, your host for today. So today we are going to explore a lot about tuberculosis care in India and its impact through digitalization. We are delighted here to have among us Dr. Harsh Shah, a distinguished public health specialist with vast experiences in designing health policies, programs, and evaluating systems. He has played a key role in National Health Mission for maternal and child health care, contributing immensely. And currently, he is also serving as assistant professor and national health coordinator at Indian Institute of Public Health, Gandhinagar. So let's get to know more about all these insights through him directly. So, sir, welcome you.
Thank you.
So your journey spans a lot in planning, financing, now teaching, and also now recently through digital transformation. So how, before going into the crux of tuberculosis and its care in India, I wanted to ask about your experience to enter into this field of public health.
Yeah, thank you. So over the period, I've worn many hats in many sizes. So I could not remember that what went well and how I came with the different roles. But over the period, what I learned that what the situations comes at the time, I played accordingly. And in the public health, when you do have a basic fundamentals clear, you can work on many different roles also. In the initial phase, I was working as a medical officer. Then I shifted as a program manager at the district level and then at the regional level. So from the medical officer treating to the patients, then working to the communities, it has a different roles. But the fundamental of having the public health sense is bigger than having the treating one patient. So that went well over the period, and whatever the roles I come across, I played carefully, and simultaneously there is a desire to make it more impactful. So I played those roles in the limited capacity, and then I got full capacity. Then I went to the planning in the policy formulation, not limited to the one stage, but I played many roles in the national guidelines also. So these kind of roles that came, you get to learn over the period, and that makes a beautiful of public health as a professional. So it teaches you, not you need to teach yourself. So that's the basic fundamental of having the public health as a profession.
That's really beautiful, like how every step has formulated to another step. So, जैसे आपने बताया, you have been in public health from different levels, from जैसे policy making हो जाए या on ground implementation, and now through digital specs. So, in all these different fields, how was your understanding of the challenges involved? Yeah, how did it play a key role in real world aspects? Because when we see through paper's lens, it's very different, but reality में अलग होता है.
Yes.
So how was your challenges? कैसे face किया?
So what I could gather that basically the public health problems nowadays are quite similar. What we see on the papers, whether it is from the newspaper, whether it is from the research publication, or whether it is from the talk that we do have internally. But each area or each community do have a different context of those problems. So when we work at the policy level, I tend to understand that कि फील्ड में जाना पड़ता है. You need to put your boots into the ground and you need to identify at what works well, and then you can work on the policy. So most of the times I spent in the field. So initial 10 years I spent in the field, and I made a practice ki every week I need to be in the field at least 2 or 3 days and in a different context. So initially I started in the immunization. Then I realized that during the one phase I realized that ki the child health is bigger than the immunization. So I shifted my focus into the child health, and this makes a different dimension. तो आप फील्ड में जाते हो, आप सीखते हो, एंड देन यू रियलाइज दैट योर the area of focusing is quite small. You need to have a macroscopic lens rather than having the small lens. And then over the period, the challenges what we faced at the local level is quite different at the policy level, at the state level, at the national level. So this makes a different scenario कि आपको हर एक चैलेंज का सॉल्यूशन वहाँ जाके मिलेगा, नॉट एट द लेवल ऑफ इन द कैबिन. एंड यू नीड टू मेक प्रैक्टिस. आई मेड अ प्रैक्टिस दैट if I come across any public health challenges, that is not limited to the disease itself, public itself, but it's the organizational challenges or the institution challenges you need to address simultaneously. तो over the period यही सीखते गए. And these challenges are not simple. As a students, I would put more emphasis that go into the field. Whenever you had interest or have an interest in certain areas, you need to go into the field and understand कि ये उस एरिया का प्रॉब्लम है, नॉट द एंटायर कंट्री और एंटायर स्टेट और एंटायर सिटी और एंटायर टाउन. And different dimension you need to explore, not limited to the particular areas. And be patient. आपको इंतज़ार करना है और वही आपका एक रूल होना चाहिए कि वॉट एवर यू लर्न यू नीड टू एब्सॉर्ब एंड यू नीड टू बी रिसेप्टिव एवरी टाइम. So that's what I've been trying. So that's what I learned from this experience.
So ये सारे questions जो थे, we covered public aspect and stigma aspects, system aspects. But जब major crux work आता है, it's India has provided a strong commitments towards TB elimination and implementation through different policies. So what do you think are like the main challenges in turning these policies into really consistent, high quality results?
So let me take you the basic indicators that we need to achieve. So as in India, as we see the global TB reports recently that has been published, and India TB reports also, we are facing almost 6 million of cases, 6 lakhs of cases to diagnose as a TB. So those TB cases, as a disease cases, they are transmitting infection to the other patients also, other persons also. And these missing cases we need to identify first. So first we need to screen most of the eligible population or the vulnerable population. Then we need to increase our diagnostic capacity. So we do have almost 6,000 plus SNART testing center across the India out of 18,000 health facilities. But still we need to increase it up to the PHC level. So abhi kya hai, NART facility means that detect drug resistance also and also the TB. The sensitivity and specificity is around 95 to 99%. Those diagnostic capacity are limited to the block level hospitals. We need to move beyond block level hospitals, and we need to ensure that whatever eligible population should go, that should avail with the advanced diagnostics. So that is the first step we need to achieve. Second is in last 3 years there is an incontinuation of drug supply. So whether it is a drug sensitive TB or the drug resistance TB, the drugs that are mandatory to the drug resistance TB, they are not in a secure supply. So there were the breaks during their course of period because those patients are having 6 months to 18 months of treatment. And if we miss 2 to 3 months, patient got resistance from particular drugs or patients had recurrence of TB again with the different bacterial load. So continuation of drug supply, securing those drug supply in all the patients. And third part is we tend to discuss more about elimination. We need to discuss about how we manage the treatment proficiently across all TB patients. So whether it is drug sensitive TB और ड्रग रेजिस्टेंट पेशेंट, हर एक पेशेंट जो रेजिमेन है उसका 6 मंथ्स का हो या 9 मंथ्स का हो या 12 मंथ्स का हो या 18 मंथ्स का, वो रेजिमेन कंप्लीट करे. सो let's forget the data, but let's count the hits. कि भाई 15 पेशेंट है या 20 पेशेंट है एट वन PHC, लेट्स एंश्योर कि हर एक पेशेंट को जो रेजिमेंट जाना चाहिए या जो डायग्नोस्टिक होना चाहिए वो कंप्लीशन पे जाए. एंड those patients who are going to miss, means migrant patients or the vulnerable patients or having the severe comorbidities, वो patients को हमें comprehensively address करना है. So these kind of challenges, the simple steps है, if we ensure these steps along with the program surveillance and monitoring, तो वो एक we can ensure that. And if you go to the developed countries, they do have an advanced surveillance system that we do not have. We more rely on lots of data. So in the TB there is a NICSHA, and NICSHA almost consume 600 data points, and how much we are going to use we don't know. So let's create an intelligent surveillance system where we can have easy surveillance, actionable surveillance, and that also easy for healthcare workers who are going to feed those systems. So dual action we need to ensure, and these kind of steps we need into the program itself, not at the national level, at the state level also, and at the local level also, to eliminate TB. Or there is a concept that 2025 we are going to eliminate TB, which is not possible for India. So we need to relook to those data, we need to do the modeling of those data, and what is the actual timeline that are required और वहाँ पे focus करना है rather than going with the political dimension. So that's my take, that this way we can reduce, but there are lots of other ideas also, but due to time constraint we can talk about these also.
Yes, sure. वो तो है. Dr. Harsh, we have spoken about Nikshay Setu and its government approach through Nikshay Setu app. But what are the low-tech approaches like dots हो गए या home visits, peer support? How were those challenges faced? What were the real differences between using Nikshay Setu and these low-tech approaches?
See, there are low-tech approaches like at the community level. So basically we do have at the facility level interventions and the community-based intervention. When we talk about peer support groups in TB or in chronic diseases also, if you go to the developed countries, there are peer groups that are being held regularly, and they discuss about the challenges they face during the course of disease itself and how they had overcome those challenges to get well or the healthy from current status. In India, the dimensions are different. Based on the geography itself, based on the gender itself, based on the age group itself, they are having the different kind of interventions. If you go to the Jharkhand, I work in Jharkhand, they do have a strong community support. But when you go to the Goa, when you go to the Maharashtra, in the metro cities, in urban areas, in the slum areas, they do not have the community support. They are coming from the different states, different types of migration. We need to make something customized for each of the geography, each of the population. There are lots of interventions at the TB space or in the health space that we can put leverage on achieving healthy community. TB champions are one of them. Those who had survived TB very well, they are designated as TB champion or TB survivor, and they used to do a hand support to each TB patient. There are different kind of community volunteers who are creating local TB forum where similar kind of peer education they used to provide to all the TB patients and the family members of TB patients. For adolescent girls, there is a stigma for adolescent girls having the TB or the communicable disease. They are handled differently. So ASHA, ANM and the Gram Sanjeevani Samiti or the local committee of women, they used to conduct the sessions and they help the TB patient or the persons with the TB to overcome those challenges. So dots, home visits, they are inbuilt within the system. But for geographical variation, we need to customize it differently. So if you think about search, Gadchiroli, they had created Village Mitra. ठीक है? Same way in Jharkhand, they had created Sahiya and now has been converted in Asha. In Chhattisgarh, there are Mitathins. Earlier, they were not Asha, but from that, Asha word came. So there are different kind of system. We need to identify that what works well at the local level, and there could be a different members also within the community who do have an influence on particular groups. So these kind of low tech solutions we need to identify, and best thing is you need to go into the field. You need to explore those areas, you need to meet the people, you need to meet the beneficiaries, and then you can learn something that what works well for community mobilization, community awareness, and ultimately community betterment. So
Overall, customization is like the key for
yeah,
any geography, any work.
yes. So basically, what we did in the previously when I was in the field also, we created a group of sarpanch, but that had not worked well. We went for the particular vaccine preventable diseases, and specifically in the child pneumonia and PPH prevention. We created a group with the sarpanches. That had not worked well. So we went ahead and we went for the milk organization committee. So in villages of Saurashtra it worked well, but when I went to the Jharkhand, we had a different contextualization. So at that level, they do have a forums at the village level, and those forum contains only the elderly. So that works well for Jharkhand also. So these kind of different dimensions we need to identify, and as you say, customization is the key, and you need to constantly explore those keys that what works well for this law.
तो उसके लिए फील्ड पर जाना ही पड़ेगा.
Obviously.
Yes, government has taken various steps, especially through this revolution of Nikshay Setu. So I wanted to know, how is this revolution framing in the clinical scenarios of diagnostic and the treatment for TB? How is it helping the patient side? Say?
Basically, the digitalization nowadays is advancing medical care. Yesterday I was in Delhi when we talked about precision clinical care. The new term that has coined that precision public health, and that works in the both way, the diagnosis at the patient level and diagnosis at the community level. Now the AI models are equipped with so much of data that they can be adopted to screen a large number of population. Second thing, the precision level of those models, those AI models, not limited to the TB. When we talk about breast cancer, when we talk about cervical cancer, when we talk about oral cancer. So AIMS is working with the ISC on oral cancer AI model. The Niramaya and the Punjab government is working on breast cancer and cervical cancer models. There are established radiological AI models in India that works on USG, that works on X-ray, that works on CT scan. And now the MRI is being developed for AI models. So these models are being tested, being piloted in India, and India is going to change every aspects of digitalization in diagnostic itself. We are using as of now for the screening purpose, not for confirmatory diagnosis, and it should be used like this way, that assist the medical officer or medical doctor or medical professional to make a decision in the right direction and in easy way. So as of now, the digitalization in terms of diagnostic is gearing up, and within 5 years, that takes time, but within 5 years we will have an advanced diagnostic system in India. Now coming back to the patient management, so the consultation part, the follow-up part, for rehabilitation part. I had a talk with a couple of scientists from the developed countries where they had created a PMS, patient management system, and that do have advanced chatbots where they can run with the patient. So patient has to install similar kind of application where they generate the data with the conversational. So during the conversational, so LLM is large language model has been installed within that app. So patient converse with the application and those alerts can directly send to the doctors who are consulting or who are checking those patients. So LLM and these kind of techniques are being used widely in the developed countries, and now India is developing this kind of space. So Apollo Hospital, the Yashoda Hospital, they have recently invested almost many of the tech specs or tech stacks in these areas, and soon we will have PMS at the advanced hospitals. Now the real challenge is the people who are actually need, and that takes time. Hopefully within 5 to 10 years the government would able to create that infrastructure through the VDM, and I hope we can all contribute in those areas.
So there is always the collaboration should be there. Apollos,
Obviously.
privates, and the public should always. I feel there should be a bridge so that for the public it will be easy to get.
That is entirely different.
Okay.
So that would require equity and equality, and in India we do not have that laws till date. So each digital application where it has been created, and if they are created with the big hospitals, it takes time to reach at the field level. And I hope through the ABDM and as you suggested, over the period we can bridge those gaps prominently and with the help of advanced digitalization through the application or through the infrastructure.
अभी बहुत ज़्यादा बात हो गई टीवी के बारे में, सर के इन्वेस्टमेंट्स के बारे में एंड ऑल ऑफ दिस, बट लेट्स गो टू अ छोटू अलग सा सेगमेंट, अ ब्रेक एलिमेंट फॉर यू एंटरटेनमेंट. सर, हमने आपका पूरा फोटोग्राफी का पेज स्टॉक किया था, तो
सब्सक्राइब किया था?
हाँ, सब्सक्राइब भी किया था एंड वी हैव शेयर्ड इट टू द होल क्लास एंड एवरीथिंग. तो हमने बस एक दो फोटो लिए थे, तो हम जानना चाहते थे, क्यूरियस थे हमारी टीम जानने के लिए कि व्हाट इज द स्टोरी बिहाइंड ये दोनों फोटोज.
सेकंड फोटोग्राफ पे आता है. सेकंड फोटोग्राफ जो है बेसिकली ये वाराणसी का है. बेसिकली इट वाज कैप्चर्ड ऑन मणिकर्णिका घाट एंड इट इज़ फेमस घाट. ऑल यू मस्ट बी नोइंग अबाउट मणिकर्णिका घाट. सो I was roaming around that ghats and with the camera in my hand, and suddenly I saw that many of the enthusiastic who are capturing selfies along with the burning dead bodies. So I found that frame. I was surprised to see this kind of behavior. I have not seen somewhere, and this was one of the photo where I captured. I converted into black and white because the man was wearing saffron color dress, the t-shirt and shorts in the saffron color, and it has written as Ram likha tha ya kuch likha tha. I couldn't remember. So I converted into black and white, and that image strikes out in a different context. So I like this image also profoundly during my entire Varanasi trip, and that's the story. Second image is I guess that is from Goa. So I usually early riser. I used to get up mostly at the 5 o'clock or 5:30, and it was we were there during the vacation. So I guess अथर्व का बर्थडे, बच्चे का बर्थडे था. I was there, and it was with the beach aligned जो resort था वहाँ पे था, and I used to rise early. So I was supposed to capture a dog here,
Okay.
So if you see the next subsequent image, you could find a dog or the cycle, a person going with the cycle, and far flung there was a boat also. So I was supposed to capture a boat between those two trees, but bird मिल गया.
हाँ, bird मिल गया.
तो वो capture हो गया. So these images are from
इसका black and white में why is it?
So वो क्या होता है कि basically when you start the painting ना, you put the strokes, and when you put the strokes, you identify that the color needs to be have the different hues. I'm more like towards the color images. मुझे black and white भी पसंद है, but certain contrast works well. So cloudy weather है, you could not see the blue sky, or blue hour का capture है basically, and the before sunrise का capture है, and the blue color could not came out well. जो contrast section है तो black and white में ज़्यादा अच्छा हुआ. So that's why I created in black and white.
मैं अपना पॉइंट ऑफ व्यू दूँ. जब मैंने ये वाराणसी का फोटो पहला देखा था, I didn't think it's वाराणसी. I thought it's a urban space. Buildings है सारा, and this fog or smoke felt like pollution. So I thought you're covering the pollution.
Climate change.
I thought climate change के बारे में बात करेंगे, तो ये थोड़ा spiritual हो गया. So this was our wholesome questions and an interactive session with Dr. Shah. आप कुछ ऐड करना चाहेंगे?
सब कुछ तो पूछ लिया.
पूरा नहीं छोड़
As
दिया.
a teacher, when you give the mic or when you give the cameras to the any teacher, the space and the time comes short. So वो एक होता है कि politician होता है एक teacher होता है. So whatever you give, that is the less compared to what they want to talk about. And similar goes to the public health person. So when you ask their experience about anything, वो हमेशा शॉर्ट होता है. सो पॉडकास्ट की बात करते हैं तो आप मूवी भी क्रिएट कर सकते हैं, बट सिंस वी हैव डिस्कस मोस्ट ऑफ द थिंग्स एंड विच इज़ रिलेवेंट टू द एनी बडिंग पब्लिक हेल्थ प्रोफेशनल, माई जस्ट लास्ट टिप इज प्लीज गो इन टू द फील्ड, स्पेंड इनिशियल ईयर्स ऑफ पब्लिक हेल्थ. When you go for the job, identify those jobs who are most related with the public health, with the field also. And you go to meet people, you need to meet healthcare workers, you need to identify what kind of challenges they are facing, not particularly people also, but healthcare workers. And last thing, कोई एरिया स्पेसिफिक मत करो, मुझे RCH पसंद है, मुझे TB पसंद है, मुझे ये पसंद है. Go for everything, make your fundamentals clear, and after some of the years you can think about going upwards. So starts from basics and then gain the experience. That's all.
Truly said. So thank you for being a part of our podcast episode.
Thank you for having me.
Your expertise and insight about has a tremendous value towards our discussion and in general in the public health aspect. So we really appreciate your time and your thoughts that you've put into today. I'm sure the audience would have taken great benefits from his experience and through public health perspectives. Thank you for tuning in. Don't forget to subscribe and join us next time for much more engaging conversations. Until next time, stay tuned.